Welcome to this Pearl of Laboratory Medicine, brought to you by AACC and the Clinical Chemistry Trainee Council. View this and many more pearls, as well as other free educational material at traineecouncil.org.
Hello, my name is Qing Meng. I'm the Section Chief of Clinical Chemistry and Professor in the Department of Laboratory Medicine at the University of Texas MD Anderson Cancer Center. Welcome to this Pearl of Laboratory Medicine on hypercalcemia, causes, and laboratory investigation. This talk is to provide a brief review on calcium homeostasis, to discuss the causes of hypercalcemia, and hopefully to identify laboratory approach to hypercalcemia. Calcium is the fifth most common element and the most prevalent canine in the body. There's approximately 1 kilogram of calcium in human body. Of these, 99% of calcium is distributed in the bones, 1% in soft tissues, and only 0.1% in body fluids. In the blood, virtually all of the calcium is in the serum or plasma, which is approximately 8.6 to 10.2 milligram per deciliter, with the ionized calcium concentration 1.13 to 1.32 millimole per liter. The intracellular concentration of calcium is about 10,000 times less than that in the extracellular fluid. Calcium exists in 3 physiochemical states in plasma. Approximately 50% is free or ionized calcium, which is the biologically active form. Approximately 40% is bound to plasma protein, and 10% is complex with small anions such as bicarbonate, lactate, citrate, and phosphate. Of the protein-bound calcium, approximately 80% is associated with albumin and 20% associated with globulin. The calcium binding to negatively charged proteins or anions is pH-dependent. Calcium homeostasis is mainly regulated by parasite hormone or PTH and 1,25-dihydroxy vitamin D. PTH is secreted by parasite glands in response to low serum ionized calcium. The physiological function of calcitonin on calcium homeostasis is not significant. Pharmacological dose of calcitonin reduces blood concentration of calcium against the action of PTH. Calcium homeostasis is mainly regulated by these 3 hormones through 3 organs, which are bone, kidneys, and intestine. Circulating calcium is excreted by glomerular filtration and reabsorbed in the proximal tubules. This table summarizes the function of the 3 hormones on the calcium homeostasis. PTH increases bone resorption to release calcium and phosphate from bone. Increased renal distal tubular reabsorption of calcium inhibits tubular reabsorption of phosphate, activates 1-alpha hydroxylase, and stimulates conversion of 25-hydroxy vitamin D to 1,25-dihydroxy vitamin D in kidneys. Increased 1,25-dihydroxy vitamin D would enhance calcium and phosphate absorption by intestine, and thus PTH indirectly acts on the intestine for calcium absorption. PTH response is very sensitive to change in serum ionized calcium, either being secreted or shut off as appropriate, and PTH may be the only hormone responsible for minute-to-minute regulation. 1,25-hydroxy vitamin D maintains calcium homeostasis in 3 ways. It increases calcium and phosphate absorption by the small intestine, weakly increases calcium and phosphate resorption from the skeleton, weakly promotes the reabsorption of calcium ions by the kidney, while calcitonin decreases plasma calcium and phosphate by inhibiting bone resorption, stimulating incorporation of calcium and phosphate to bone against the effect of PTH on bone resorption, reducing reabsorption of calcium and phosphate by kidneys. Overall, the physiological role of calcitonin in calcium control is not clear. It may only respond to a fairly large increase in ionized calcium. It is used clinically in treatment of hypercalcemia and in certain bone disease by suppressing bone resorption. It is more important in regulating bone remodeling than in calcium homeostasis. There are numerous factors can cause hypercalcemia, including pre-analytical, analytical, biological, and pathological. For pre-analytical errors, these include tourniquet use and venous occlusion, which is associated with increased protein-bound calcium or total calcium, but not ionized calcium, fixed cleaching, or forearm exercise that can decrease pH and increase the ionized calcium. Hyperventilation, causing respiratory alkalosis, reduce ionized calcium without change of total calcium. Change in the posture, such as standing, decrease intravascular water and increase protein concentration, and thus total calcium. Prolonged immobilization and bed rest increase both total and ionized calcium levels. Contamination with the calcium from corks, glassware, tubes, and drywall increase calcium level. There are also analytical interference such as hemolysis, icterus, lipemia on spectrophotometer or ISE. There are a number of pathological disorders can cause hypercalcemia. These are increased parathyroid hormone due to primary hyperparathyroidism, sporadic familial multi-endocrine neoplasia type 1 or MEN2A, secondary and tertiary hyperparathyroidism. Some case coexisting malignancy and primary hyperparathyroidism, ectopic PTH in malignancy. Malignancy, which is characterized as a humoral hypercalcemia of malignancy, as mediated by parathyroid hormone-related protein, which is the PTHRP. Also due to local osteolysis in multiple myeloma, other malignancies such as breast cancer, lung cancer. Increased vitamin D, mainly 1,25-dihydroxy vitamin D, that can be seen in granulomatous disease, such as sarcoidosis, tuberculosis. Vitamin D intoxication can be due to vitamin D supplements, vitamin D metabolites, or analogs. Lymphoma. Renal failure, for example, chronic renal failure with treatment with calcium and 1,25-dihydroxy vitamin D or vitamin D analogs. Recovery phase of rhabdomyolysis and acute renal failure. Renal transplant. Other endocrine diseases such as hyperthyroidism, adrenal insufficiency, acromegaly, pheochromocytoma. Medications include thiazide diuretics, lithium-related release of PTH, milk alkali syndrome, vitamin A intoxication, theophylline. Other causes such as immobilization with high bone turnover, seen in Paget's disease, bedridden child, familial hypocalciuric hypercalcemia, Williams syndrome, hyperphosphatemia, acute hypomagnesemia. In general, primary hyperparathyroidism and cancer accounts for 90% of the cases of hypercalcemia. For outpatients, 90% of the cases have primary hyperparathyroidism. For inpatients, approximately 65% of the cases have cancer and 25% of the cases are due to primary hyperparathyroidism. In primary hyperparathyroidism, the increased calcium levels are due to excessive PTH secretion from parathyroid adenoma or hyperplasia, multiple gland enlargement, including MEN1, MEN2, familial hyperparathyroidism, carcinoma, which is very rare, and familial benign hypercalcemia. Hypercalcemia results from combined effects of PTH-induced bone resorption, intestinal calcium absorption, and renal tubular reabsorption. The pathophysiological change of hypercalcemia is related to the combined effects of excessive secretion of PTH and production of 1,25-dihydroxy vitamin D. Primary hyperparathyroidism is diagnosed based on the intake of PTH and other chemistry panel. PTH is usually elevated despite elevated serum calcium. Serum phosphate is in the low normal to mildly decreased range. Serum alkaline phosphatase increased and with hyperchloremic metabolic acidosis. urine calcium is normal to slight increase. 24-hour urine calcium excretion is used to rule out familial hypocalciuric hypercalcemia. The values below 100 mg 24 hours urine or a calcium creatinine clearance ratio of less than 0.01 are suggestive of familial hypocalciuric hypercalcemia. Whether to use ionized calcium versus serum total calcium, there's still a debate. Some labs do, and some labs only use total calcium, and there's approximate correlation with the ionized calcium. Also, some labs, especially in Europe, use corrected serum calcium. There are many equations, but here is the most commonly used one, and the serum calcium plus 0.8 multiplied 4 minus albumin. The hypercalcemia of malignancy is attributed to excessive bone resorption by one of three mechanisms. Humoral hypercalcemia of malignancy is due to overexpression of PTH-related protein, or PTH-RP, that affects bone and kidney similar to PTH. Increased expression of PTH-RP is seen in squamous cell carcinoma, for example, lung, head and neck, esophagus, cervix, carcinoma of ovarian, breast, and renal. Increased 1,25-dihydroxy vitamin D synthesis by lymphomas, local osteolytic hypercalcemia in multiple myeloma. This accounts for 20% of all hypercalcemia of malignancy. A number of laboratory tests can be used for assessment of hypercalcemia. These include serum total calcium, ionized calcium, albumin, PTH, 25-hydroxy vitamin D, and 1,25-dihydroxy vitamin D, acid-base status, electrolytes, magnesium, bicarbonate, serum BUN creatinine, serum phosphate, serum or urine protein electrophoresis, 24-hour urine calcium to creatinine ratio, or urine creatinine. Urinary cyclic adenosine monophosphate, CAMP, PTH-RP, is also ordered in suspected malignancy. More specifically, the following initial laboratory tests should be ordered. Total calcium is very reliable. You may correct calcium value if albumin decreased using the following formula or equation. If calcium is elevated above 11 mg per deciliter, then order intact PTH, along with other tests such as ionized calcium, electrolytes, including BUN and creatinine, phosphate. If PTH is elevated or normal, suggests hyperparathyroidism, then order 24-hour urine calcium. If urine calcium is high, that suggests of primary hyperparathyroidism. If urine calcium is low, then familial hypocalciuric hypercalcemia. If PTH is low, then order PTH-RP or consider other testing for vitamin D excess, milk alkaline syndrome, and hyperthyroidism. If PTH is low or normal, then order vitamin D, the 25-hydroxy vitamin D and 1,25-dihydroxy vitamin D. If vitamin D level is high, suggestive of lymphoma or granulomatous disease. If vitamin D is low, consider testing for cancer. If PTH-RP is high, it is suggestive of cancer. If needed, additional tests or examination should be performed. For example, chest X-ray, renal function test, complete blood count, erythrocyte sedimentation rate or CRT, serum alkaline phosphatase, liver function test, thyroid function test, serum cortisol. Here is the algorithm we have developed for the investigation of hypercalcemia. Due to the time constraint, I won't repeat as most of these tests and procedure we have already discussed. In summary, primary hyperparathyroidism and cancer are the most common causes of hypercalcemia. Intact PTH is the most important test in the differential diagnosis of hypercalcemia. A 24-hour urine calcium and calcium to creatinine ratio are helpful. PTH-RP should be measured if cancer is suspected. Tests for other causes of hypercalcemia should be ordered for differential diagnosis. and investigation algorithms should be established in each institution. Thank you again for joining me on this Pro of Laboratory Medicine on hypercalcemia causes and laboratory investigation.
For more like this, as well as articles, podcasts, and more, please visit the Trainee Council at traineecouncil.org.